Pediatric congenital heart disease. CHD incidence, 5 to 8 per 1,000 live births. Major cause of death in first year of life, after prematurity. Most common anomaly is VSD. 28% of kids with CHD have another recognized anomaly, trisomy 21, 13, 18, plus. 5 to 8/1,000 live births, excluding PDAS in pretermers. Trisomy 21 equals Downs. 30 to 50% have structural heart defect. Most common defect with Downs is endocardial cushion defects, ACD equals A.S.D, and VSD. Syndromes commonly associated with CHD: Noonan syndrome, Williams syndrome, Holt-Oram syndrome, DiGeorge syndrome. Causes of CHD: chromosomal/genetic equals 10% to 12%. Maternal or environmental equals 1% to 2%. Maternal drug use. Fetal alcohol syndrome, 50% have CHD. Maternal illness. Rubella in first 7 weeks of pregnancy. 50% risk of defects including PDA, patent ductus arteriosus, and pulmonary branch stenosis. CMV, toxoplasmosis, other viral illnesses. Cardiac defects. IDMs, infants of diabetic mothers, equals 10% risk of CHD, VSD, cardiomyopathy, TGA, transposition of great arteries most common. Multifactorial equals 85%. Etiology of congenital heart disease. Percent of all lesion. Obstructive lesions, coarctation aortic/pulmonary stenosis. Acyanotic lesions. VSD 30 to 35. ASD. PDA. Cyanotic lesions. Tetralogy of Fallot 5 to 7. Transposition of great arteries 3 to 5. Truncus arteriosus 1 to 2. Total anomalous pulmonary venous return 1 to 2. Tricuspid atresia 1 to 2. Pulmonary atresia 1 to 2. Hyperplastic left heart syndrome 1 to 2. 4. Older classifications of CHD. Acyanotic. May become cyanotic. Cyanotic. May be pink. May develop CHF. Very confusing. Newer diagnostic categories now. Newer classification of CHD. Hemodynamic characteristics. Increased pulmonary blood flow. Decreased pulmonary blood flow. Obstruction of blood flow out of the heart. Mixed blood flow. Table on page 1476 in blue, 1595 in orange. Increased pulmonary blood flow CHF. Decreased pulm blood flow cyanosis. Obstructive defects: decreased blood flow out of the ventricles. Obstructed left heart CHF. Obstructed right heart cyanosis. Mixed blood flow. Depends on the degree of mixing. May have hypoxemia with or without cyanosis. May have CHF also. Increased pulmonary blood flow defects. Abnormal connection between two sides of heart. Either the septum or the great vessels. Increased blood volume on right side of heart. Increased pulmonary blood flow. Decreased systemic blood flow. Patients present with symptoms of congestive failure. Increased pulmonary blood flow defects. Atrial septal defect. Ventricular septal defect. Patent ductus arteriosus. Obstructive defects: coarctation of the aortic stenosis. Pulmonic stenosis. Decreased pulmonary blood flow defects. Tetralogy of Fallot. Tricuspid atresia. Pulmonary blood flow is obstructed plus have defect of ASD or VSD. Blood backs up in our side of heart. Causes desaturated blood to shunt to the left, and into systemic circulation. Usually hypoxemic and usually cyanotic. Most common defects are TET and tricuspid atresia. Mixed defects: transposition of great vessels. Total anomalous pulmonary venous connection. Hyperplastic heart syndrome. Right. Left. Blood is mixed from pulmonary and systemic circulations within the heart chambers. Relative desaturation of blood in systemic blood flow. Cardiac output decreases because of volume load on ventricle. Signs of desats, cyanosis, and CHF, but variable depending on anatomy. Atrial septal defect. Normally, oxygen-poor, blue, blood returns to the right atrium from the body, travels to the right ventricle, then is pumped into the lungs where it receives oxygen. Oxygen-rich, red, blood returns to the left atrium from the lungs, passes into the left ventricle, and then is pumped out to the body through the aorta. An atrial septal defect allows oxygen-rich, red, blood to pass from the left atrium, through the opening in the septum, and then mix with oxygen-poor, blue, blood in the right atrium. Definition. An atrial septal defect is an opening in the atrial septum, or dividing wall between the two upper chambers of the heart known as the right and left atria. Hemodynamics. RT. Atrium receives blood from sup. And INF. Vena cava and from LT. Atrium. RT. Atrium enlarges. Hemodynamics. Large volume of blood from RT. Atrium passes THIU normal tricuspid valve and pulmonary valve. Delayed diastolic murmur low LT sternal border. RT. Ventricle enlarges. Pulmonary ejection murmur. Hemodynamics pulm. Valve closes late and P2 is delayed. RV is fully loaded, so further rise in RV volume cannot occur. Widely split S2. Fixed split S2. Accentuated S2. Presentation: recurrent chest infections, fatigue, sweating, rapid breathing, shortness of breath, poor growth. On examination: inspection, parasternal impulse palpation, systolic thrill at second LT space, auscultation, wide fixed split S2, accentuated P2, ESM at LT second and third interspaces, delayed diastolic murmur at low LT interspace. CXR findings: mode, cardiomegaly, RA enlargement, RV enlargement, prominent main pulm artery, plethoric lung fields, ACG changes, RT axis deviation, RT vent hypertrophy, RSR pattern in V1, echo pictures. Severity assessment. Intensity of the two murmurs. The heart size. Complication: pulmonary hypertension, above 20 years. Disappearance of diastolic murmur. Appearance of pulm ejection click. Loud palpable P2. P2_ still widely split. Management: medical antibiotics for chest infections. Digoxin to increase work of heart. Didex to reduce preload. Repair. Surgical repair devices. Ventricular septal defect. Second most common CHD 32%, congenital heart disease. Synonyms: Rogers disease, interventricular septal defect, congenital cardiac anomaly. Pathophysiology primarily depends on size and status of pulm, vascular bed rather than location. Small communication, less than half a centimeter, VSD is restrictive and right. Ventricular pressure is normal, does not cause significant hemodynamic derangement. QPQ_S equals 1.75 to 1.0 equals ratio of pulmonary/systemic blood flow. Moderately restrictive VSD with the moderate shunt, QPQ_S equals 1.5 to 2.5 to 1.0, and poses hemodynamic burden on LV. Large non-restrictive VSDs, more than 1.0 centimeters, right and left ventricular pressure are equalized. QPQs is more than 2 to 1. Large VSDs at birth, PVR, pulmonary vascular resistance, may remain higher than normal and left to right shunt may ideally limited. Involution of media of small pulm. Arterioles, PVR decreases, large left to right shunt ensues. In some infants large VSDs, pulm. Arteriolar thickness never decreases. Pulm. Obstructive disease develops. When QPQ_S equals 1 to 1 shunt becomes bidirectional, signs of heart failure abate and PT becomes cyanotic. Eisenmenger syndrome. Anatomical classification. Type A membranous septum. paramembranous/paramembranous defect, or infracrystal, subaortic, conoventricular. Type A muscular septum. Inlet, trabecular, central, apical, marginal or Swiss cheese. Type A outlet septum deficient. Supracrystal, subpulmonary, infundibular or conoseptal. Septal deficiency of septal defect, of canal. Clinical features: race, no particular racial predilection. Sex, no particular sex preference. Age, infants difficult in postnatal period, although CCF during first 6 mths is frequent, X-ray and D.C.G. Normal. Children, after first year variable clinical picture emerges. Small VSD, asymptomatic. Large VSD, common symptoms: palpitation, dyspnea on exertion, feeding difficulties, poor growth. Frequent chest infections. Physical findings: pulse pressure is relatively wide. Precordium is hyperkinetic with a systolic thriller. LSB left sternal border. S1 and S2 are masked by a PSM at left tenant. Sternal border, max. Intensity of the murmur is best heard at 3rd, 4th and 5th left tenant interspace. Also well heard at the 2nd space but not conducted beyond apex. Presence of mid-diastolic, low-pitched rumble at the apex is caused by increased flow across the mitral valve and indicates QPQ'(S equals 2 to 1/ greater. Maladidroja small VSD presenting in older children as a loud PSM without other significant hemodynamic changes. Investigations: echocardiography, 2-dimensional and Doppler collar flow. Chest radiography. Normal. Biventricular hypertrophy. Pulmonary plethora. Electrocardiography. Small FS normal tracing. Mod.VSD broad, notched P-wave characteristic of left tenant atrial overload as well as LV overload, namely, deep Q waves and tall R waves in leads V5 and V6 and often AF. Large VSD RVH with right axis deviation. With further progression biventricular hypertrophy, P waves may be notched/peaked. Other investigations: CAT scan, computed axial tomography, MRI. Ultrasound. Angiography. Cardiac catheterization and angiography. Complications: congestive cardiac failure. Infective endocarditis on right ventricular side. Aortic insufficiency. Complete heart block. Delayed growth and development, FTT, in infancy. Damage to electrical conduction system during surgery causing arrhythmias. Pulmonary hypertension, intervention: 3 major types: small, less than 3 mm diameter. Hemodynamically insignificant. BW 80 to 85% of all VSDs. All close spontaneously. 50% by 2 years. 90% by 6 years. 10% during school years. Muscular close sooner than membranous. Newborn VSD most common lesion 2/3 itis close spontaneously. Small VSD. Definite murmur. Will probably close. Large VSD. No murmur. No problems. Home with mum. Moderate VSDs. 3 to 5 mm diameter. Least common group of children 3 to 5%. Without evidence of CCF/PULM.HTN can be followed until spontaneous closure occurs. Large VSDs with normal PVR, pulmonary vascular resistance. 6 to 10 mm in diameter. Usually requires surgery otherwise. Develop CCF, congestive cardiac failure, and FTT, failure to thrive, by age of 3-6 mths. Conservative treatment. Treat CCF and prevent development of pulm.vascular disease. Prevention and treatment of infective endocarditis. Evaluation of cyanotic heart disease. 44. Physical examination: central cyanosis versus peripheral cyanosis. Vital signs. Lung and SNES examination to rule these out. Cardiac examination. heaves, thrills, abnormal or increased precordial activity, absent or diminished femoral pulses, abnormal first or second heart sound, abnormal splitting, extra heart sounds, gallop, ejection click, opening snap, murmurs that are loud, harsh, blowing. 45. Physical exam. Initial evaluation of child's heart. Listen to heart first when/if infant quiet. Warm stethoscope. First concentrate on S1 and especially S2. Louder than normal. Split normally. Systolic murmur. Starts after or obscures S1. Diastolic murmur. Widely radiating murmur. Palpate liver. BP in arm and leg. Tongue, cyanosis. History. Difficulty feeding, irritability, diaphoresis, perspiring profusely, failure to thrive, FTT. Prenatal history, maternal diabetes, SLE. Congenital infections, torch. Drugs taken in pregnancy. Family history, heart problem before 50 years. O. Chromosomal abnormalities. 47. Lab/imaging studies. CBC/sepsis evaluation. Chest X-ray. Oxygen saturation, arterial blood gas, pulse oximetry. Hyperoxia test. Electrocardiogram. Echocardiography. A hyperoxia test is a test that is performed usually on an infant to determine whether the patient's cyanosis is due to lung disease or a problem with blood circulation. It is performed by measuring the arterial blood gases of the patient while he breathes room air, then remeasuring the blood gases after the patient has breathed 100% oxygen for 10 minutes. If the cause of the cyanosis is due to poor oxygen saturation by the lungs, allowing the patient to breathe 100% O2 will augment the lungs' ability to saturate the blood with oxygen, and the partial pressure of oxygen in the arterial blood will rise, usually above 150 mm of mercury. 48. Transposition of great arteries. Second most common cause of cyanosis in infancy. Pulmonary and systemic circulations form two separate circuits. Must be mixing between two circuits for life. Egg-shaped silhouette. 49. Clinical findings. Severe cyanosis present at birth. 1/3 have VSD, some have ASD. Some have subpulmonic stenosis. Loud, single S2. Systolic murmur indicates VSD or pulmonic stenosis. ACG reveals right ventricular hypertrophy. 50. Transposition of great arteries, Texas. PGE1 administration necessary. Balloon atrial septostomy necessary, Rashkind procedure. Arterial switch procedure performed first week of life. 51. Hyperplastic left heart. Presence first week of life, as PDA closes symptoms develop. PGE administration. Ductal dependent systemic blood flow. 52. Tricuspid atresia. Tricuspid valve fails to develop. Hypoplasia of right heart. Venous blood from right atrium depends on open ASD or PFO, VSD, PDA. 53. Tricuspid atresia. Clinical findings. Progressive cyanosis as PDA closes. 30% transposition of great arteries. 70% some degree of pulmonic stenosis. Tachypneic, single S2. Systolic murmur along left lower sternal border, VSD. ACG reveals left ventricular hypertrophy. 54. Truncus arteriosus. Failure of primitive truncus arteriosus to divide into aorta and pulm A. VSD almost always present. Right-sided arch in about 33%. Cardiomegaly, increased pulmonary vascularity, right aortic arch. 55. Tetralogy of phyllocomenist cyanotic congenital heart disease. 10% of all congenital heart diseases. 4 morphological defects. Morphology. 4 morphological defects. Ventricular septal defect. Right ventricular outflow tract obstruction. Subvalvar. Valvar. Supravalvar. Overriding of the aorta. Right ventricular hypertrophy. Morphology of normal heart. Morphology MTOF. Subvalvular obstruction. Tetralogy of low boot-shaped heart. Most common cause of cyanotic heart disease beyond neonatal period. Degree of pulmonary stenosis and size of VSD determine presentation. Variable degree of cyanosis. Boot-shaped heart. 60. Altered physiology. Obstruction to flow of deoxygenated blood from the right ventricle to the pulmonary artery. Decreased oxygenation due to poor perfusion of the blood. Altered physiology. Shunting of deoxygenated blood from the right ventricle to the aorta across the ventricular septal defect, facilitated by aortic override. Poor systemic oxygenation, low hemoglobin saturation and cyanosis. Clinical presentation. Cyanosis not usually noticed at birth. Causes. Child less active in the initial few months. Fetal hemoglobin has more affinity for oxygen than adult hemoglobin. Clinical presentation. Cyanosis manifests more as child becomes more active. Physical growth is greater than good less than. Mental development may be delayed in severe cases due to chronic hypoxia of the brain. Clinical findings: squatting TET spells due to pulmonary outflow tract spasm. Severe cases at birth. Severe PS pulmonary stenosis. Mild cases, much later mild PS. Cyanosis usually. ACG reveals right ventricular hypertrophy. 65. Cyanotic spells typical of Fallot's tetralogy. Usually occurs when the child cries or is very active, as when the child wakes up from sleep. Cyanotic spells activity results in increases oxygen demand. Decreases systemic vascular resistance. Increases sympathetic activity, which causes infundibular spasm, i.e., increase in the muscular obstruction to the right ventricular outflow at the subvalvular level. Squatting typical of Fallot's tetralogy. Child assumes squatting posture very frequently. Some postures may be called squatting equivalents. Reason is that squatting causes an increase in resistance to systemic flow, decreased shunting across the VSD, less desaturation of systemic blood. Natural history. Wide spectrum of clinical manifestations depending on severity of abnormalities, i.e., degree of obstruction to right ventricular outflow, and size of VSD. Treatment options. Only surgical. Palliative surgery. Definitive surgery. Palliative surgery. Aim to divert systemic blood into the pulmonary circulation and thus enhance pulmonary flow and oxygenation. Standard operation is the modified Blalock-Taussig shunt or other systemic pulmonary shunts such as Potts shunt and Waterston-Cooley shunt. Systemic to pulmonary shunts. Tetralogy of Fallot. Treatment of TET spell knee chest position O2. Morphine 0.1 to 0.2 mg/kg, 4. Phenylephrine GTTS, increase systolic BP 20 to 40 mm of mercury. Beta blockade, for example propranolol, titrate to 0.1 mg/kg. ABG, narco 3 if necessary. Surgery, definitive surgery. Relief of right ventricular outflow tract obstruction. Separation of systemic and pulmonary circulations by closure of the VSD. Treatment strategies. Palliative surgery in early childhood followed by definitive surgery in the later years, usually after 3 to 4 years of age. Definitive surgery in the neonatal period or early childhood, TOF in adult cardiac surgical hospital. Delayed definitive repair following shunt in early childhood. Delayed presentation, for definitive repair. Reoperation for delayed complications after definitive repair. Patent ductus arteriosus. Patent ductus arteriosus. The ductus arteriosus in the fetus is an important conduit that allows deoxygenated blood to bypass the collapsed lungs and enter the placenta through the descending aorta and umbilical arteries. Patent ductus arteriosus. The placenta acts as an oxygenator and returns oxygen-rich blood through the umbilical vein and ductus venosus to the fetal heart. The placenta produces prostaglandins, which maintain prenatal patency of the ductus and, in early gestation, inhibit the ability of the ductus to contract in response to oxygen. Patent ductus arteriosus. During the postnatal period, final closure of the ductus arteriosus results from increased production of local vasoconstrictors, like endothelin, in response to higher arterial oxygen, removal of placental prostaglandin and a decrease in the number of prostaglandin E2 receptors in the ductal wall. Patent ductus arteriosus. The direction of blood flow across the PDA depends on the balance of pulmonary and systemic vascular resistance. Patent ductus arteriosus. The most reliable non-invasive diagnostic tool is echocardiography with Doppler ultrasound. In most infants, a modified parasternal short-axis view offers the best window for PDA visualization. This view offers the best opportunity to directly measure the PDA. Patent ductus arteriosus. Patent ductus arteriosus. The secondary effects of the increased flow can estimate the volume load from the left to right ductal shunt. A large shunt leads to dilation of the left atrium and left ventricle, as well as holodiastolic reversal of blood flow distal to the ductus in the descending aorta due to runoff into the pulmonary bed. Patent ductus arteriosus. The clinical features depend on the magnitude of left to right shunt through the PDA and the ability of the infant to initiate compensatory mechanisms to handle the extra volume load. Relationship to systemic organ perfusion with PDA. Redistribution of systemic blood flow occurs even with moderate shunts. Retrograde aortic flow, decreased systemic blood flow, and moderate hypotension are common in premature infants with a PDA and may lead to decreased perfusion in many organs, with potential clinical consequences to each. Relationship to systemic organ perfusion with PDA. Reduced cerebral blood flow or changes in cerebral blood flow velocity patterns have been implicated in the occurrence of intraventricular hemorrhage. Renal function may be compromised, and myocardial perfusion, particularly subendocardial blood flow, may be reduced. PDA consequences: pulmonary edema, pulmonary hemorrhage, bronchopulmonary dysplasia, incidence of necrotizing enterocolitis, incidence of intraventricular hemorrhage, signs and symptoms 2 to 3 days after birth up to 1 week of life. Later in those treated with surfactant. Prominent left ventricular impulse, bounding pulses, widened pulse pressure, greater than 25 mm of mercury. Murmur. Can be initially silent. Initially systolic becoming continuous. Machinery-like. Treatment of PDA. Simple fluid restriction along with diuretic use is often recommended to control the symptoms of a PDA. Furosemide is commonly used. Although furosemide is a prostaglandin agonist, it does not interfere with PDA closure. Treatment of PDA. The use of oral or, preferably, intravenous, lyophilized, indomethacin to constrict the ductus arteriosus has led to successful non-surgical closure in a large proportion of treated infants. The effects of indomethacin apparently are best when it is administered before 10 days of age and in less mature infants. Treatment of PDA. Dose schedules vary, but commonly a first dose of 0.2 mg/kg is given by nasogastric tube or intravenously. For intravenous indomethacin, subsequent doses depend on the age at initial treatment. If less than 48 hours, the subsequent 2 doses are 0.10 mg/kg, if 2 to 7 days, 0.20 mg/kg, and if greater than 7 days, 0.25 mg/kg. A total of 3 doses usually is given 12 to 24 hours apart depending on urinary output. If urine flow decreases, fewer doses may be used or the time between doses may be extended. Treatment of PDA: surgical ligation. In small infants that are not a candidate for, or who have failed, medical therapy, surgical ligation remains an effective alternative.